Fatima and Navya, you have to present today's seminar. Fatima and Navya, unmute yourselves. Share your screen. Navya. You can start the seminar.
Good morning everyone, this is Navya and today my topic is surgical management of cataract. Indications for surgical management: visual improvement, medical indications such as lens-induced glaucoma, phacoanaphylactic endophthalmitis, retinal diseases such as diabetic retinopathy and retinal detachment, and cosmetic indications to attain black pupil. Preoperative evaluation: general medical examinations to evaluate any systemic diseases such as diabetes and hypertension, any renal diseases, and ocular examinations for visual acuity, perception of light, projection of light rays, test for function of peripheral retina, laser interferometry or potential acutiometer, anterior segment evaluation, and intraocular pressure.
Navya, if possible, come to the other room. There is a lot of sound from outside is there. If possible, come to the other room.
Okay, sir. Intraocular pressure rise in IOP needs prior management. Examination to rule out any conjunctival and lacrimal sac infections. Macular function test, 2 light discrimination test, Maddox rod test, color perception and entopic visualization. And keratometry and biometry to calculate the power of intraocular lens to be implanted. Preoperative medications and preparations. Consent should be taken and scrub bath, care of hair and marking of the eye to be operated. Antibiotics and disinfectants should be given. Topical antibiotics for 4 days, four times for 3 days, and every 15 minutes for 2 hours before surgery. Povidone iodine as a single drop 10 to 30 minutes before surgery to decrease any bacterial flora. IOP lowering drugs should be given. IV mannitol or estazolamide can be given. Mydriatics for the pupil dilation, topical tropicamide plus phenylephrine should be instilled every 15 minutes for 4 to 6 times before surgery. Anesthesia, cataract extraction can be performed under general or local anesthesia. Local anesthesia is preferred normally. Surgical techniques for cataract extraction are two types: intracapsular extraction and extracapsular cataract extraction. Intracapsular cataract extraction. The entire cataractous lens along with the intact capsule is removed. Therefore, weak and degenerated zonules are prerequisite for this method. So it is done only in the age of 40 to 50, for above the age of 40 years. Indications for ICC is subluxated and dislocated lens. Surgical steps for ICCE. Superior rectus bridal suture to fix the eye in downward gaze. Conjunctival flap is done to expose limbus and hemostasis is achieved by Wetfield cautery. Partial thickness groove about 2/3 depth of anterior limbal area from 9 to 2 o'clock with razor blade knife is done. Corneoscleral section is completed using sclerocorneal scissors. Peripheral iridectomy is performed by iris forceps and Devexer scissors to prevent postoperative pupil blood glaucoma. Methods of lens delivery. Smith Indian method. In this method, lens is delivered by applying pressure on limbus at 6 o'clock position and with lens expressor, and counter pressure at 12 o'clock position, and in lower pole of the lens is delivered first. And cryo extraction method. In this method, cryophobe is applied on the anterior surface of the lens and freezing is done to create adhesion between lens and the probe. The zonules are ruptured gently, rotatory movements, and lens is then extracted. Capsule forceps method. Forceps is introduced close into the anterior chamber and the anterior capsule of the lens is caught at 6 o'clock position. Zonules are ruptured and the lens is extracted. Iroshek method and Iris-Hoek method and Weir-Vectis method. In Weir-Vectis method, loop of the Weir-Vectis is slide gently between the subluxated lens, which is then lifted out of the eye. Formation of anterior chamber after delivery of lens iris is deposited into anterior chamber with iris repositor, and chamber is formed by injecting balanced salt solution. Implantation of anterior chamber. Closure of the incision with 5 to 7 interrupted sutures. Conjunctival flap is reposited. Subconjunctival injection is given of 0.2 ml dexamethasone and 0.5 ml gentamicin is given. Patching of the eye with pad and sticking plaster or a bandage. Surgical techniques for extracapsular extraction. It is of three types: conventional extracapsular cataract extraction, manual small incision cataract extraction, and phacoemulsification. Conventional extracapsular cataract extraction. Surgical steps are superior rectus suture to fix the downward gaze of the eye, conjunctival flap, partial thickness groove, entry into the anterior chamber, injection of viscoelastic substance into the anterior chamber. It maintains the anterior chamber and protects endothelium. Anterior capsulotomy. It is of can openers technique, linear capsulotomy, and continuous circular capsulorhexis. In can openers technique, cystitome is introduced into the anterior chamber and multiple small radial cuts are made in the anterior capsule. In linear capsulotomy, a straight incision is made in the anterior capsule from 2 to 10 o'clock position. The rest of the capsulotomy is completed in the end. In continuous circular capsulorhexis, entire capsule is torn in circular fashion, either with the help of irrigating bent needle cystitome or with capsulorhexis forceps. Removal of anterior capsule. It is removed with the help of Kelman-McPherson forceps. Completion of corneoscleral section from 10 to 2 o'clock position using blunt keratome. Hydrodissection is done with balanced salt is injected on the peripheral anterior capsule. It separates the corticonuclear mass from the capsule. Removal of nucleus by using pressure and counter method or irrigating wire vectis method. In pressure and counter pressure method, pressure is applied at 12 o'clock position with corneal forceps and nucleus is expressed out by at 6 o'clock position. In wire vectis method, irrigating wire vectis is passed below the nucleus, which is then lifted out. Aspiration of cortex. Remaining cortex is aspirated using two-way irrigation and aspiration cannula. Implantation of intraocular lens. PMMA. Posterior chamber intraocular lens is implanted in capsular bag after inflating the bag with viscoelastic substance. Closure of incision with 3 to 5 in continuous or interrupted sutures. Removal of viscoelastic substance. Conjunctival flap reposition, subconjunctival injection, and patching of the eye. Advantages of ECCE technique over ICCE. ECCE can be performed at all ages except when zonules are not intact, whereas ICCE cannot be performed below 40 years of age where zonules are intact. Posterior chamber intraocular lens can be implanted in ECCE, which cannot be done in ICCE. Post-operative vitreous-related problems are not seen in ECCE. Post-operative complications such as endophthalmitis, cystoid macular edema are less with ECCE. Post-operative astigmatism is less with ECCE as incision is small. Second method is manual small incision cataract surgery. In this technique, intraocular lens implanted is performed through sutureless self-sealing valvular sclerocorneal tunnel incision. Surgical steps include superior rectus suture, conjunctival flap, sclerocorneal tunnel. It consists of following components. They are external scleral incision, sclerocorneal tunnel, internal corneal incision. External scleral incision, 1/3 to half thickness external scleral groove is made about 1.5 to 2 mm behind the limbus. It may be straight, front shape or sclerocorneal tunnel. It is made with the help of crescent knife. It usually extends from 1 to 1.5 mm into the clear cornea. Internal corneal incision. It is made with the help of sharp 3.2 mm angle keratome. Side port entry. Side port entry about 1.5 mm valvular corneal incision is made at 9 o'clock position, which helps in aspiration of subincisional cortex and deepening the anterior chamber. Anterior capsulotomy. Large size CCC is preferred normally, and hydrodissection is done. Nuclear management, it consists of prolapse of nucleus out of the capsular bag into the anterior chamber, is usually initiated during hydrodissection and completed by rotating nucleus with Sinskes hook. Delivery of the nucleus outside by one of the following: irrigating Vectis method, Blumenthal's technique, and Facco fracture technique. Aspiration of cortex, intraocular lens implantation, removal of viscoelastic material. Excessive left out of viscoelastic material may cause secondary glaucoma. Wound closure, anterior chamber deepens with balanced salt solution injected through side port tunnel. This leads to self-sealing of incision with valve effect. Phacoemulsification. The surgical steps include corneal incision. Very small incision is made with 3 mm keratome. Continuous corneal capsular axis of 4 to 6 mm. Hydrodissection. Separation of capsule from the cortex by injecting fluid between them. Nucleus is emulsified and aspirated by phacoemulsifier. Different techniques used are chip and flip technique, divide and conquer technique, stop and chop, direct phaco chop technique. Remaining cortical lens matter is aspirated with the help of irrigation aspiration technique, foldable intraocular lens implantation with the help of injector. Surgical technique of ECCE for childhood cataract. It includes irrigation and aspiration of lens matter and lensectomy. Irrigation and aspiration of lens matter. It is done by corneoscleral tunnel technique, which include manual irrigation aspiration technique, phaco aspiration technique. And surgical steps are superior rectus suture, conjunctival flap and exposure sclera, hemostasis, sclerocorneal tunnel incision 3 to 4 mm and side port entry. Anterior capsular axis about 5 mm size is made. Hydrodissection is done. Irrigation and aspiration technique methods include manually with two-way irrigation and aspirations, Simcoe cannula with phaco probe. Posterior capsular axis about 3 to 4 mm size to avoid posterior capsule opacification. Anterior vitrectomy is done. Implantation of intraocular lens. Foldable acrylic lens are preferred. It induces less cellular reaction and are more adhesive to the capsular bag. Removal of viscoelastic material and intracameral antibiotics are given. Wound closure is done. Lensectomy. It includes, in this procedure, most of the lens including anterior and posterior capsule along with the anterior vitreous are removed. It is done in either pars plana or limbal method. In pars plana approach, lens is punctured at its equator and stayed with the help of Ziegler's or any other needle knife. The cutter of the vitrectomy knife is introduced after enlarging the sclera. Thank you.
We have go back again, right from starting from your start.
Sir?
Start from ICC again. Start your PPT again.
Okay, sir.
ICC. Okay, go. Okay. Next. Generated prerequisite for this method. Okay, go ahead. So one thing is, in the investigations, whenever you do a cataract surgery, you will have to see the patency of nasolacrimal passages. Okay, that's the most important. Suppose if you have a dacryocystitis, chronic or acute, at the same time when you are operating, it proves actually fatal for the visual outcome of the eye. Okay.
Okay. Okay, sir.
That you have not mentioned. And second thing is, go ahead, ICC, show me the steps of surgery. Steps of surgery for ICC, intracapsular.
This.
Okay, superior rectus, conjunctival flap. What type of conjunctival flap actually you are going to make in case of ICC? Is it a limbal-based conjunctival flap or fornix-based conjunctival flap? You haven't mentioned. So normally when we were doing actually intracapsular cataract extraction, it was only a limbal-based conjunctival flap. Okay. After we do the surgery, we used to spread the conjunctival flap up again, and then we used to put the sutures for the conjunctiva also. And second thing is, you said cryo extraction. So what's the gas used for doing this cryo extraction? What's the amount of temperature generated at the tip of the cryoprobe? So these are the questions.
Minus 40 degrees centigrade.
Minus 40 degrees centigrade.
Minus 40 degrees centigrade.
You haven't mentioned that in your talk. Okay. And this is iriso-fake method, not iriso-ake method.
Okay, sir.
Okay, go ahead. Come on, forward it. Implantation of anti-air chamber. What is implantation of anti-air chamber? You must mention implantation of anti-air chamber IOL. Even in your talk, you didn't say that.
Okay.
Okay. Closure of position with 5 to 7 interpreted sutures. What type of material actually used for putting the sutures there?
Nylon thread. Nylon thread.
10-0 nylon or 80 silk. Normally we used to use it whenever we had done actually ICCD. And you should also mention that the sutures must be radial and equidistant, so that the post-operative suture-induced astigmatism will be less. Okay. Okay. Go ahead. Still.
Okay,
no. Still. Forward it. So whenever actually you mention various steps, conjunctival flap is done with the particular scissors. So from such a o'clock to 10 to 2 o'clock, the conventional extra capsule. And entry at 12 o'clock is made with Levin blade. So that also you should mention.
Okay.
Next.
Okay, sir.
Next. Forward it. And aspiration of the cortex, irrigation aspiration cannula. Good. Go ahead. Forward it. So whenever you are putting the sutures, you are mentioning about the sutures, you should mention what material actually you use it. Okay?
Okay, sir. Okay, sir. Okay.
So advantage interest in the mind. CCE can be performed. Okay. Next, forward it. Okay, next. What is the purpose of hydrodissection? So these are the questions we ask in the examination. That's the reason I'm telling you again. Purpose of hydrodissection.
To separate corticonuclear mass from the posterior capsule.
Very good. Nicely verified and mentioned. Okay. Next. What is fish hook technique? Do you have any idea?
No, sir. No, sir.
Okay, that's fine. Go ahead. Okay, that's good. You have done well. These points actually you will have to keep in your brain and answer the questions whenever asked in the examination. Okay. Good, Navya. Okay, you can conclude
Okay,
your
sir.
question.
Thank you, sir. Thanks.
Does Fatima share your presentation? Fatima, unmute yourself and share your presentation.
This is Fatima Patan. I'm going to discuss about complications of cataract surgery. Complications of cataract surgery. They are mainly pre-operative, operative, in post-operative, early post-operative, and delayed post-operative, and intraocular lens-related complications. In pre-operative complications, first one is anxiety. It is due to fear and apprehension of the operation. It can be treated by using anxiolytic drugs like alprazolam or diazepam. Irritative or allergic conjunctivitis. It is due to use of pre-operative topical antibiotic drops. Complications due to local anesthesia. Retrobulbar hemorrhage. It is due to retrobulbar block. It can be managed by using immediate pressure bandage after instilling 2% pilocarpine drop. Oculocardiac reflex. It manifests as bradycardia or cardiac arrhythmias. It is due to retrobulbar or peribulbar block. It can be treated with an IV injection of atropine. Perforation of globe. Subconjunctival hemorrhage. It is a minor complication which is observed frequently. It can be resolved on its own. Dislocation of lens. It is seen mainly in patients with degenerated zonules, hypermature cataract, and vigorous ocular massage after retrobulbar block. Operative complications. Superior rectus muscle laceration. It is superior rectus muscle laceration occurs while applying bridal suture in ECCE or SICS. Usually, no treatment is required for superior rectus muscle laceration. Excessive bleeding. It is mainly during a preparation of conjunctival flap or scleral incision. In incision-related complications, irregular or conventional method of ECCE, it is due to use of blunt cutting instruments. Buttonholing of anterior wall of tunnel. It occurs because of superficial dissection of the scleral flap. Premature entry into the anterior chamber. It occurs because of deep dissection. And scleral disincision can occur due to very deep groove incision. Injury can occur to cornea, iris, and lens. If injury to cornea occurs, there may be Descemet membranes detachment. It is due to use of sharp tipped instruments like keratome or razor blade. Injury to iris can cause iridodialysis, where there may be tear of iris from root. There can be injury to lens. Anterior capsulorhexis. In anterior capsulorhexis, continuous curvilinear capsulorhexis is preferred technique. Escaping capsulorhexis. Here the capsulorhexis moves peripherally and may extend to the equator or posterior capsule. Small sized capsulorhexis. It predisposes to posterior capsule tear and nuclear drop and also occurrence of jonular dehiscence. Very large capsulorhexis. And eccentric capsulorhexis, it leads to IOL decentration. Posterior capsular rupture. It can lead to nuclear drop into the vitreous. And posterior capsular rupture can occur due to forceful hydrodissection, direct injury with instruments such as Sinski's hook, chopper, etc., and during cortex aspiration. In cortex aspiration, it may occur accidentally. Jonular adhesions, most common during nucleus prolapse into the anterior chamber in small incision cataract surgery. Vitreous prolapse and loss may occur due to accidental rupture of the posterior capsule. Measures to prevent vitreous loss. Vitreous to decrease vitreous volume. Vitreous volume can be decreased by using hyperosmotic agents like mannitol, 20% mannitol or oral glycerol. To decrease aqueous volume, we will use acetazolamide and adequate ocular massage. To decrease orbital volume, adequate ocular massage and orbital compression is used to decrease orbital volume. Better ocular echinacea and anesthesia, which decreases the pressure from muscles of eyeball, minimizing the external pressure on eyeball. Posterior sclerotomy with drainage of vitreous when intraocular pressure is high. Nucleus drop into the vitreous cavity. It occurs more frequently with phacoemulsification due to sudden and large posterior capsular rupture. Posterior loss of lens fragments occurs after posterior capsular rupture or jonular adhesions during phacoemulsification. It may result in glaucoma, chronic uveitis, retinal detachment. It can be treated by pars plana vitrectomy and removal of nuclear fragments. Expulsive choroidal hemorrhage, mainly seen in hypertensive patients and along with patients with arteriosclerotic changes. Early post-operative complications. Hyphema. It is a collection of blood in the anterior chamber, maybe from the conjunctival or scleral vessels, or rarely from the root of iris. It can be managed by spontaneous absorption or by use of acetazolamide and hyperosmotic agents if intraocular pressure increases, or paracentesis. Iris prolapse. It is due to inadequate suturing of incision after intracapsular cataract extraction and conventional extracapsular cataract extraction. It is absent in manual small incision cataract surgery and phacoemulsification technique. It can be managed by in less than 24 hours. Striate keratopathy, characterized by mild corneal edema with Descemet's folds. It is mainly due to endothelial damage during surgery. Flat or shallow anterior chamber. It is rare complication due to rarely due to wound leak or wound ciliochoroidal detachment or pupil block. Flat anterior chamber with wound leak with hypotony can be tested by Siddle's test. Ciliochoroidal detachment. It can be managed by immediate pressure bandage or oral acetazolamide. Pupil block due to vitreous bulge leads to the formation of iris bombay and shallowing of anterior chamber. If it persists, permanent peripheral anterior syncae formed leading to secondary angle closure glaucoma. In pupil block, we will use mydriatic hyperosmotic agents like 20% mannitol and acetazolamide. Post-operative anterior uveitis. It is induced by instrumental trauma, undue handling of uveal tissue. It can be treated using topical steroids, cycloplegics, and NSAIDs. Toxic anterior segment syndrome. Bacterial endophthalmitis. The main sources of infection are contaminated solutions, contaminated instruments, surgeons' hands, patient's own flora from conjunctiva, eyelids, and airborne bacteria. Signs and symptoms include ocular pain, diminished vision, lid edema, conjunctival chemosis, corneal edema, etc. Delayed post-operative complications. First is cystoid macular edema. It is the fluid in the form of cystic loculi in Henle's layer of macula. In fundoscopy, we will see honeycomb appearance. In fluorescein angiography, we will see a typical flower petal pattern. Etiopathogenesis is associated with vitreous incarceration in the wound and mild iritis and some prostaglandins. It can be prevented by use of pre-operative and post-operative use of antiprostaglandins like indomethacin or ketorolac eye drops. It can be treated by anterior vitrectomy with steroids and antiprostaglandins. Delayed chronic post-operative endophthalmitis. Causative organisms are Propionibacterium acne or Staph epidermidis within the capsular bag. Fungal endophthalmitis is due to delayed post-operative endophthalmitis. It can be treated by using pars plana vitrectomy or antifungal drugs. Pseudophakic bullous keratopathy. It is a continuation of post-operative corneal edema by surgical or chemical insult. Common indication of penetrating keratoplasty. Retinal detachment. It is higher in aphakic patients than phakics. More common after intracapsular extraction technique than extracapsular extraction technique or IOL implantation. Risk factors include vitreous loss, myopia, and lattice degeneration. Epithelial growth. Rarely, conjunctival epithelial cells invade the anterior chamber through a defect in incision. Abnormal epithelial grows and lines back of cornea and trabecular meshwork, leading to intractable glaucoma. In late stages, it can extend on the iris and the anterior part of vitreous. Fibrous downgrowth. It is in the anterior chamber when the cataract wound apposition is not perfect. It can cause secondary glaucoma, disorganization of anterior augment, and thesis bulbae. After cataract, secondary cataract common post-operative complication causes residual opaque lens matter and proliferative type. In clinical types after cataract, tenuous posterior capsule opacification, dense membranous after cataract, Soemmer's ring, which is a thick ring of after cataract formed behind the iris between the two layers of capsule. Earlsing spirals, it is in which the vacuolated subcapsular epithelial cells are clustered like soap bubbles in the posterior capsule. Thin membranous after cataract is thickened posterior capsule and dense membranous after cataract, Soemmer's rings. Glaucoma in aphakia and pseudophakia. IOL related complications. Complications like cystoid macular edema, corneal endothelial damage, uveitis, and secondary glaucoma are seen more frequently with IOL implantation. UGH syndrome refers to uveitis, glaucoma, hyphema, which occur with rigid anterior chamber IOL, which is not used nowadays. Malpositions of IOL. Sunset syndrome, there is an inferior subluxation of IOL. Sunrise syndrome, there is superior subluxation of IOL. Lost lens syndrome, there is a complete dislocation of IOL. And windshield wiper syndrome. Pupillary capture of the IOL is a post-operative iritis or proliferation of the lens fibers. Toxic anterior segment syndrome. There is the uveal inflammation by the ethylene gas used for sterilizing IOLs or by the lens material. It is characterized by inflammation and may be differentiated from endophthalmitis.
Started from beginning again.
So there is intraocular lens, types of intraocular lens. Sir, I have ended the
You do
topic.
that, complete that answer.
Types of intraocular lens. The first intraocular lens for the treatment of cataract was implemented by Harold Ridley. Parts of an intraocular lens. Optic. It is the part of the lens that focuses the light on retina. Haptic. Small filaments connected to the optic that hold the lens in place of eye. Types of intraocular lens. These are based on the method of fixation in the eye, depending on the material of manufacturing, based on the focusing ability of intraocular lens, aphakic versus phakic refractive intraocular lens, and special function intraocular lenses. Based on the method of fixation, first one is the anterior chamber intraocular lens. These are also called as angle supported intraocular lens. These are not very popular, but these lie in front of the iris and supported by the angle of anterior chamber. Most commonly used anterior chamber IOL is Kelman multiflex. Anterior chamber IOL can be inserted after in ICCE or ECCE. Posterior chamber IOL, it lies behind the iris. And most commonly used are capsular back fixation of PC IOL method. Example, C-loop, quadriloop. Ciliary sulcus fixation of posterior capsule IOL, posterior chamber IOL in absence of intact capsular bag but with adequate capsular support. Scleral fixation of posterior chamber IOL in absence of capsular support. Retroiris fixation, implanting iris claw lens in posterior chamber. Iris supported lens. They are fixed on the iris with the help of sutures, loops, claws. Example, Singh and Wohr's iris claw lens. Depending on the material of manufacturing, there are rigid intraocular lenses made up of PMMA polymethyl methacrylate, foldable intraocular lenses. These are made up of silicone, acrylic, hydrogel. These are implanted after phacoemulsification with 3.2 mm incision with the help of IOL injector. If these are thin foldable IOLs, they can be implanted with 2 mm incision. Rollable intraocular lenses. These are made up of hydrogel. These are very ultra thin. They may be through 1 mm incision after micro incision cataract surgery. Based on the focusing ability of intraocular lenses, these are unifocal intraocular lenses, multifocal intraocular lenses, and accommodative intraocular lenses. In unifocal intraocular lenses, they have unifocal power. They can correct either myopia or hypermetropia, but they cannot correct both. Multifocal intraocular lenses are simultaneous visual lenses or pseudo-accommodative intraocular lenses. These are two types, refractive or diffractive. Accommodative intraocular lenses. These show anterior movement of optic to improve near vision. Example, crystal lens, which is based on the optic shift principle. Synchrony lens, based on the dual optic mechanism. Extended depth of focus intraocular lenses. These are most popular. Example, Technis Symphony. They can correct as near vision to some extent due to its elongated focus. Aphakic versus phakic refractive intraocular lenses. In addition to aphakia intraocular lenses, which are implanted after lens extraction, they can correct both. Implantable columnar lenses. Special function intraocular lenses. These are to provide some special function in addition to correcting aphakia. Toric intraocular lenses. They correct astigmatism along with aphakia. Aspheric intraocular lenses. They reduce spherical aberrations. Aniridia intraocular lenses. They are used cosmetically to cover defects of aniridia or partial iris loss in trauma. Calculation of intraocular power. This is based on SRK formula, Sanders, Retzlaff and Kraft. Power of intraocular lens, P equal to A minus 2.5 L minus 0.9 K, where A is the constant which is specific for each lens type. L is the axial length of eyeball in mm, which is measured by A-scan ultrasonography, and K is an average corneal curvature which is measured by keratometry. Thank you.
Go back.
Yes.
Start from the beginning. Basically, we have preferred actually, as you mentioned, the complications for each technique separately. Okay. So the preoperative complications, they are the same for everything almost. But the postoperative or perioperative complications, they differ actually for intracapsular cataract extraction, extracapsular cataract extraction, small incision cataract surgery, and also phacoemulsification. And the other lady, I think Navya, she hasn't mentioned about laser-assisted cataract surgery. Femtosecond laser, she has not mentioned it. And she should have mentioned actually in her talk. Okay. Let me see. This is operative. So as I said, actually you should mention the complications for intracapsular cataract extraction separate, extracapsular conventional one, small incision cataract surgery, and then phaco. So what complications can occur and which is more frequent and which is more dangerous? Understand?
Okay.
So
Yes,
I think that's how actually it is given in your textbooks also.
Yes, sir.
Go ahead. Let me see your PPT once again. Preparation of the globe. Anterior capsular rhexis. What is the ideal rhexis? What is the ideal size of rhexis? How much size actually you expect to do when you are doing capsular rhexis? That's also given in your textbooks. Normally you must mention it. You will ask last one. Last time? Extended large rhexis, small rhexis, and you should know what is the normal size of actual rhexis. Go ahead. I think your colleague has mentioned it. capsular rupture can lead to nucleus drop, and this is actually more common in case of phacoemulsification. It's an unforgiving complication. One should be very, very careful. The moment we see actually a small rent in the Gaucher capsule, we should stop and try to salvage the eye. Otherwise, actually, the patient will lose the eye. Now, the thing is actually once it drops into the Gaucher segment, we have to send it to the vitreoretinal surgeon for retrieval of the nucleus and again putting a scleral fixation IOL or other types of IOLs in the Gaucher chamber itself. Okay. Expulsive cilioporoidal hemorrhage. This is actually a dreaded complication, and you have mentioned about it. That's good. Go ahead. Early post-operative complications. Suppose if the hyphema is left unattended, what will happen?
Sir?
If the hyphema is left unattended, that means you don't treat it actually. The patient goes out and he doesn't return, even if he has a hyphema, what will happen?
Endophthalmitis.
Oh. Anything else? Blood staining of the cornea can occur, which may necessitate actually a penetrating keratoplasty. Okay.
Yes, sir.
So the thing is, if it is a small hyphema, you can leave it like that.
Yes, sir.
Suppose if it is a moderate one, you give actually escitalopram and even cycloplegics in certain cases, and an antibiotic, anti-inflammatory, all these things. Suppose if it is a large one, if it is not actually getting absorbed after 48 hours also, we do actually a paracentesis.
Okay, sir.
So when you do a paracentesis, that also you should mention. Iris prolapse. So how do you manage this iris prolapse? So usually these people, they come say after 48 hours or so for the first follow-up on the third day, and sometimes you may see actually an iris prolapse. So how do you manage this iris prolapse? Leave it like that?
Suture.
So iris which is prolapse, what are you going to do with it?
We will suture it, sir.
No. The iris which is prolapse, where are you going to suture? Which area you are going to suture? So normally, suppose if we think actually the iris is healthy and it is already covered with conjunctiva and it is not sloughed and the texture of iris is as normal as other part of the iris, so then we try to repose it back into the anterior chamber and then we put a suture. Suppose if the iris is already not healthy, in such conditions, what we do is we do an abscission of the iris and then put a suture. Okay?
Yes, sir. Yes, sir.
Striate keratopathy, how do you manage striate keratopathy?
In mild conditions, it will disappear spontaneously.
Very good.
In moderate conditions, we will use hypertonic saline drops
Okay, very good.
along with steroids.
So there are certain grades of actually striate keratopathy. I don't think it's necessary by people, but if the cornea has gone for a corneal decompensation, there's grade 4 striate keratopathy. In such conditions, we may require actually a penetrating keratoplasty. We'll have to do that. Otherwise, the patient will not have any vision. Okay.
Okay, sir.
Next. What is Siddle's test? How do you do it?
By using fluorescein.
Okay.
We will instill a fluorescein in the lower fornix and we will ask the patient to blink his eye.
Okay.
We will see if the dye is spreading evenly or not. And if there is any leakage.
Where do you look for leakage? So normally what we see is we see the incisional line. If there is dilution of the fluorescein stain in the particular area, that indicates actually there is a leakage from that point. So there actually we put a suture.
Okay, sir.
Choroidal detachment. How do you diagnose choroidal detachment? It is given in your books.
It appears as brownish mass
Hmm?
in the anterior chamber.
The anterior chamber. Where is choroid? Is it in the anterior chamber or posterior chamber?
Posterior.
Then how do you see choroidal detachment in the anterior chamber? Okay, go ahead. So bacterial endophthalmitis is also a dreaded complication.
Yes, sir.
The patient actually who was having good vision and is a quiet eye in the immediate post-operative period, when he comes in the first for the first follow-up on the third day or so, you will
Yes, sir.
complain that the vision has come down, and there will be other signs as you have mentioned. Okay.
Okay,
So how
sir.
do you manage this?
By using steroid.
Anything else? So you make actually aqueous tap and also vitreous tap, send them actually for gram stain and other stains, and
Yes,
also the culture and sensitivity. And you give broad spectrum antibiotics intravitreally. Okay.
Yes, sir.
So another thing actually, bacterial endophthalmitis, if you suspect it, you can do a B scan where you see that actually hazing completely. There are a lot of opacities in the vitreous. That's what you can see actually on the B scan. Okay.
Okay, sir.
That actually nearly confirms actually endophthalmitis. So you will have to make an aqueous tap and vitreous tap, and later on you will have to go to where you are going to inject actually the intravitreal injections, vancomycin, ceftazidime, along with the decadron. Okay.
Okay,
So
sir.
these are the drugs normally we inject intravitreally, and we see actually the progress of the case. Suppose if the vision has come back to near normal and the symptoms have abated, in such conditions actually we repeat actually the injection after 48 hours. So suppose if there is no improvement, in such conditions actually we send the patient to require surgeon for pars plana vitrectomy. Okay.
Okay, sir. Yes, sir.
Next, delayed post-operative complications, cystoid macular edema. Okay, next. Chronic post-operative endophthalmitis, fungal endophthalmitis. Next. Acute syndrome. Okay, next. Next. So what is Irwin gas syndrome?
Sir.
Irwin gas syndrome.
Don't know, sir.
Verify it and tell me. You have my number, I take it from somebody else and then tell me. Okay, next. What's over? Pupillary capture of the IOL, toxic anti-septic syndrome. So how do you manage this toxic anti-segment syndrome? TAS? I think it's given in your books. Check it out, TAS minus. How do you manage this TAS? Fatima, you
Sir.
don't know?
No, sir.
You must read all these things because these things we ask you in the examination. Okay,
Okay,
well
sir.
done. Okay, thank you.
Thank you, sir.
Rape, tomorrow actually you are going to present a case. So the
Yes,
first
sir.
10 people I think we have given it, and we will send you actually the photograph of a case and also a little brief history of the patient's compliance, everything. And you will have to write down a case sheet as you do it and we pick up one of the persons in the 10, and then you will have to present your case. So it depends. Tomorrow I may ask the 5th man or 6th number or 9th number to present the case, and we'll have to present it. And we ask questions to all these 10 people, and you will have to answer them. Okay. So I think in the evening we are going to send it to your mail. I think we'll put it in your group because we'll have to give you time actually even in the examination, 40 minutes for your long case and about 10 minutes for your short cases. So what we are going to do is we put it in your group this evening, WhatsApp group.